Welcome to Bookfulness. We're back for deep dive number 36. And today we're definitely broadening our scope, moving beyond just one region like we did with the oral cavity last time, and really casting a wider net.
That's right. We're kind of spanning the body today, pulling insights from our source material on, well, a few really key systems. We're talking about the lower limb, the head structures, and that critical transition zone, the neck.
Yeah, a lot to cover. And our goal, as always, is to really drill down, find those crucial, clinically relevant takeaways from the text.
Not just the what, but the why. Why are certain areas prone to injury? Why do we see specific symptoms? It's about connecting that structure to function and dysfunction.
Exactly. So let's jump in. We'll start from the ground up, literally, with the lower limb, looking at its structure and how we actually walk the mechanics of gait.
Okay, so the lower limb. Development is really the place to start because it explains, well, a lot of the final adult anatomy.
Right, those limb buds, they don't just pop up randomly.
No, definitely not. Upper limbs first, C5 to T1 spinal segments. Then the lower limbs, about a week later, L2 to S2. But the really crucial part, the bit that shapes everything, is the rotation.
Ah, yes, the twist. They both twist, but not the same way.
Exactly. Both twist 90 degrees around their long axis. But, and this is key, in opposite directions. The upper limb rotates externally or laterally.
Which brings the elbow to the back and the biceps to the front. Makes sense.
But the lower limb, it rotates 90 degrees medially.
Yeah.
Inwards. It's like it permanently twists itself into pronation.
Permanently pronated. What does that actually do for us? I mean, why twist it that way?
Well, that medial twist is everything for walking upright. It swings the extensor muscles, like your quads, around to the front of the thigh. And critically, it orients the foot so the great toe, the hallux, ends up on the medial side.
Okay, so without that twist.
Our knees would point outwards, and our big toes would probably be on the little toe side. Walking efficiently, like we do, wouldn't happen. That twist is fundamental.
Wow. That's pretty complex choreography happening very early on. Okay, so from that developmental twist to the adult structure, the hip bone, the akakaka. It's not just one bone, is it?
No, it's 3 bones fused together, the ilium, the ischium, and the pubis. Each has a really specific job.
Let's take the ilium first. That's the biggest.
By far. It forms the upper flared part. You've got these thick columns medially designed purely for weight-bearing, transmitting force from the spine down. And then those big wing-like alae provide huge surface areas.
For muscle attachments.
Exactly. All those powerful gluteal muscles, the hip stabilizers, abdominal muscles. They need a big anchor point, and the iliac ala provides it.
Okay. Then there's the ischium. That's the back and bottom part.
Postero-inferior, yeah. And its most famous feature is definitely the ischial tuberosity.
The bit you sit on.
Literally, that's what bears your body weight when you're sitting. It's this big, rough projection built for it. And nearby, you've got the ischial spine, smaller but important.
Why is that important?
It's a key landmark. It separates the greater sciatic notch above it, which is the big exit for the sciatic nerve, from the lesser sciatic notch below it. Helps orient you in that complex region.
Got it. And the third part, the pubis.
That's the anteromedial component. It forms the front part of the hip bone, contributes to the acetabulum, the hip socket, and it's the main attachment point for your inner thigh muscles, the adductors.
So these 3 bones fuse together seamlessly. And you get landmarks like the iliac crest out of that fusion.
Right. The iliac crest is that long, curved superior border you can feel on yourself. It acts like a protective bumper for your abdominal organs laterally. But it's also a massive attachment site for abdominal muscles, back muscles, fascia. It's really structurally important.
Okay, so that's the static architecture. Now let's put it in motion. Walking. The gait cycle.
Right, the gait cycle. It's basically everything that happens from the moment one foot hits the ground until that same foot hits the ground again. And we split it into 2 main phases.
Stance and swing.
Exactly. Stance phase is when the foot is in contact with the ground, bearing weight. That's about 60% of the cycle. Swing phase is when the foot's in the air, moving forward the other 40%.
And it kicks off with initial contact, what used to be called heel strike. Then loading response. What's happening muscle-wise right then?
This is a moment of really precise control. You need to absorb shock and stabilize. The key players here are the dorsiflexors muscles on the front of your shin, especially the tibialis anterior, and they're working eccentrically.
Eccentric contraction. That's when the muscle contracts while it's lengthening. Seems weird.
It does, but it's crucial here. Think about it. If those muscles didn't contract eccentrically, your foot would just slap down hard onto the ground after your heel hits. Gravity would win.
Ah, so it's like a controlled lowering.
Precisely. It's a braking action. The muscle lengthens under tension to gently lower the rest of the foot to the ground, absorbs shock, keeps the ankle stable. It's all about control.
Okay, so control deceleration first,
Hmm.
but then you need to actually push forward. That comes later.
Right. The real power for propulsion comes mainly during terminal stance, leading into pre-swing. We call it push-off. And this is where the concentric contractions dominate.
Concentric meaning the muscle shortens as it contracts.
Yes, and the big powerhouses here are the plantar flexors in your calf, the triceps surae group, which is mainly the gastrocnemius and the soleus muscles,
They contract, shorten, and lift the heel.
and propel the entire body forward and upward. That powerful push-off is where most of the energy for walking is actually expended. It's the engine.
So walking is this constant back and forth between eccentric control, sort of yielding to gravity,
Yeah.
and powerful concentric pushing to overcome it.
That's a great way to put it, a continuous, coordinated dance between braking and accelerating.
Okay, let's shift gears now and talk about when things go wrong. Clinical issues.
Hmm.
Where are the common weak spots in the lower limb?
Well, a big area is during growth, especially in adolescence. Those growth plates, the epiphyseal plates, are still cartilaginous.
Not fully bone yet.
Right. And that cartilage is mechanically the weakest point in the bone. It's much more vulnerable to shear forces and tension than mature bone is.
So kids in sports.
Exactly. High impact, repetitive stress, think competitive running, jumping, football, it puts enormous strain on those plates. So you see injuries there like Osgood-Schlatter at the knee or problems at the hip that you just don't see in adults whose plates have fused. And sometimes these get dismissed as simple sprains, but they can affect growth if not managed right.
That makes sense. What about the geometry of the bones themselves? Like the femur. I know the angle of the neck is important.
Hugely important. We talk about the angle of inclination, that's the angle between the femoral neck and the femoral shaft. If that angle is decreased, it's called coxavara.
And what does coxavara cause?
It effectively shortens the limb slightly on that side, and
Ah.
because of the altered mechanics, it restricts passive abduction, moving the leg out to the side.
And the opposite.
That's coxavalga, where the angle is increased. That tends to make the limb slightly longer. Both can affect gait and joint stress over time.
And there's a specific serious issue in older kids related to this, right? The slipped epiphysis?
Yes, slipped capital femoral epiphysis, or SCFE. This is where the head of the femur actually slips off the neck at the growth plate. It's a shearing injury.
Ouch. Does it hurt at the hip?
Often, no. That's the tricky part. The pain is very commonly referred to the knee, so a kid comes in with knee pain, but the real problem is up at the hip.
That could easily be missed.
It can. And if it's not caught and treated, the slip can worsen, leading to progressive coxavara, potentially serious long-term hip problems like early arthritis.
Okay, let's move from bone structure to nerves and blood vessels. Where structures cross paths seems like a potential trouble spot. The sciatic nerve, for example.
Definitely. The sciatic nerve is the largest nerve in the body. It usually exits the pelvis below the piriformis muscle through the greater sciatic foramen. That's the standard anatomy.
But not always.
Not always. Our source mentions a common variation occurs in maybe 12% of people, where the common fibular division of the sciatic nerve, one of its two main branches, actually pierces right through the piriformis muscle.
12%.
Mm-hmm.
That's not insignificant. And if the nerve goes through the muscle,
Then that muscle can directly compress the nerve if it spasms or gets tight or swollen. This is what's often called piriformis syndrome.
so you get sciatica symptoms, pain down the leg,
Mhm.
but the cause isn't a disc in the back. It's the muscle squeezing the nerve in the buttock.
Exactly. And knowing about that anatomical variation is critical because the treatment is completely different. You need to address the muscle, not the spine.
Right. Okay, what about accessing blood vessels? The femoral artery is a big one.
It's a major access point. Its location in the femoral triangle, just below the inguinal ligament, is relatively superficial. You can find its pulse reliably midway between the acis, that bony point on the front of your hip, and the pubic symphysis.
And that accessibility is used clinically.
All the time. It's the standard site for inserting catheters for procedures like cardiac angiography.
So they thread a catheter all the way from the leg up to the heart.
Yep. Up the femoral, external iliac, common iliac, aorta, right into the heart to look at the coronary arteries. Its size and predictable path make it ideal for that. You can also compress it there against the bone in, say, a massive leg hemorrhage situation.
Okay. Now let's talk about something more hidden, a deep infection. The psoas abscess.
Ah, yes. This is a classic example of how infections can track along fascial planes. The psoas major muscle runs from the lumbar spine down to the femur, and it has its own fascial sheath.
And the abscess starts somewhere else.
Often, yes. It's frequently secondary to something deeper, like tuberculosis affecting the lumbar vertebrae, or sometimes Crohn's disease if there's inflammation near the terminal ileum, which lies close to the psoas. The infection gets contained within the psoas fascia.
And follows the muscle down.
Exactly. It tracks inferiorly within that fascial sheath. So the patient might present with a swelling or pain not in their back or abdomen, but way down in the groin or the upper thigh.
That sounds like it could look like a lot of other things.
Oh, absolutely. It's notoriously tricky to diagnose. It can mimic a hernia, enlarged lymph nodes, even a vascular issue like a saphenous varix.
So how do you tell?
History is key. Any history of TB, Crohn's, immunosuppression, and imaging, like a CT or MRI, is usually needed to confirm that the collection is deep within the muscle sheath, tracking down from above. It really highlights how deep problems can show up far away.
Okay, let's make a big jump now, all the way up to the head. The cranium, it's designed for protection, obviously, but it's not uniformly thick, is it?
No, not at all. The strength is strategically placed. We talk about cranial buttresses. These are thickened regions of bone, like along the midline front to back, the zygomatic arches on the sides, the occipital region.
And what do these buttresses do?
They act like beams or pillars in a building. When there's an impact, say a blow to the head, these thicker areas transmit the force, diverting it around the thinner, weaker areas of the skull, like parts of the temporal bone or the orbital roof. It's clever structural engineering to protect the brain inside.
That's the adult skull. How does the infant skull compare? It looks quite different.
Very different. The infant's cranial vault, the calvaria, is huge relative to the face. The face is small because the jaws, the air sinuses, they're all underdeveloped. Also, the frontal bone starts as two separate halves with a suture down the middle that usually fuses by about age 8.
And the fontanelles, the soft spots, they're important clinically, right? Not just for birth.
Critically important. They provide a window, essentially. You can gently palpate the anterior fontanelle to get a sense of the baby's intracranial pressure. If it's bulging and tense, that's a sign pressure might be too high. If it's sunken, maybe dehydration. It's a non-invasive assessment tool.
Okay, moving outwards to the scalp. Famous for bleeding. A small cut can bleed. A lot. Why is that?
It comes down to layer 2 of the scalp, the dense connective tissue layer. It's incredibly vascular, lots of arteries run through it. But that connective tissue is so dense and fibrous that it anchors the walls of these arteries.
So when an artery is cut,
Its walls can't contract effectively. They can't spasm down like they would elsewhere in the body to stop the bleeding. They're literally held open by the surrounding tough tissue.
okay, so they just keep pumping out blood until you apply direct pressure.
Exactly. That lack of natural vasoconstriction is why scalp wounds are often so dramatic, even if they're relatively minor cuts.
And beneath that dense layer, there's the danger area. Layer 4, the loose connective tissue. Why is it dangerous?
Because it's, well, loose. It's a potential space where fluids, pus from an infection, or blood from trauma can spread very easily, almost like oil on water. It can track all over the scalp, under the skin.
But the real danger isn't sideways spread, is it? It's going deeper.
That's the critical risk. This loose layer contains emissary veins. These are small veins that pass directly through holes in the skull bones, connecting the veins of the scalp outside with the dural venous sinuses inside the cranial cavity.
And the problem is these veins don't have valves.
Correct. They're valveless, which means blood, and more importantly, infection, can flow inwards from the scalp directly into the intracranial venous system. So a seemingly simple scalp infection, if it gets into that loose layer, could potentially lead to meningitis or a septic thrombosis of a dural sinus, a direct route to the brain.
That's definitely a danger area. Okay, let's talk about bleeding inside the skull from trauma. Specifically, telling the difference between extradural and subarachnoid hemorrhages.
Right. Very different causes, presentations, and implications. Extradural, also called epidural, hemorrhage is usually caused by trauma, typically a hard blow to the side of the head, often fracturing the temporal bone. This tears an artery running just inside the skull, most commonly the middle meningeal artery.
And because it's an artery, the bleeding is fast.
Fast and under high pressure. It creates a collection of blood between the duramater and the skull bone itself, hence extradural.
But isn't there that weird lucid interval sometimes?
Yes, that's the classic, though not universal sign. The initial blow might cause a brief concussion. The person recovers, seems okay for maybe minutes to hours. That's the lucid interval. But meanwhile, that arterial bleed is rapidly accumulating, compressing the brain.
Until it reaches a critical point.
Exactly. Then the patient suddenly deteriorates, drowsiness, confusion, pupil changes, coma. It's a neurosurgical emergency because the pressure builds so quickly.
Okay. How does that contrast with the subarachnoid hemorrhage?
Subarachnoid hemorrhage is bleeding into the space beneath the arachnoid mater where the cerebrospinal fluid, CSF, circulates. While it can be caused by severe trauma, it's more classically associated with the rupture of a cerebral aneurysm, like a saccular or berry aneurysm, often at the base of the brain in the circle of Willis.
So often not trauma-related, and the blood mixes with the CSF.
Right, and that mixing causes intense irritation of the meninges, the brain coverings.
Leading to that worst headache of my life.
The classic thunderclap headache. Sudden, incredibly severe headache, often with neck stiffness, sensitivity to light, photophobia, maybe nausea or vomiting, all signs of meningeal irritation. It presents very differently from the extradural bleed.
All right, let's zoom in on some specific cranial nerves and sensory structures, starting with the optic nerve, CN2. You often hear it's unique among the cranial nerves. Why?
The fundamental difference is its origin. It's not really a peripheral nerve in the same way the others are. It's technically an extension of the brain itself, a CNS tract.
Okay. And what's the clinical implication of that?
It comes down to the myelin sheath, the insulation around the nerve fibers. In the optic nerve, just like in the brain and spinal cord, myelin is made by cells called oligodendrocytes.
Whereas in true peripheral nerves,
Myelin is made by Schwann cells. It seems like a small detail, but it's huge clinically. Because the optic nerve uses oligodendrocytes, it's susceptible to diseases that attack CNS myelin.
like multiple sclerosis.
Exactly. MS is a classic example of a CNS demyelinating disease. And very often, one of the first symptoms of MS is optic neuritis inflammation and demyelination of the optic nerve, causing vision problems. The other peripheral nerves, wrapped in Schwann cells, aren't affected by MS in the same way. That cell type difference is key.
Fascinating. Okay, let's move to motor nerves. The hypoglossal nerve, CN12, controls the tongue. What happens if it's damaged?
CN12 innervates most of the tongue muscles. If you have a lesion on one side, say from neck trauma or a tumor at the base of the skull, the muscles on that side become weak or paralyzed. Specifically, the genioglossus muscle, which is responsible for protruding the tongue.
So when you ask the patient to stick their tongue out,
The healthy genioglossus muscle on the unaffected side contracts and pushes its half of the tongue forward, but the paralyzed muscle on the affected side can't push. So the net result is the tongue deviates, it points toward the side of the lesion, towards the weak side.
okay, points to the lesion. That's a clear sign. What about the facial nerve, CN8? We know it controls facial expressions, but it has a role in hearing too.
It does, via a tiny little muscle in the middle ear called the stapedius. Stapedius sends a branch to innervate it.
And what does the stapedius muscle do?
It attaches to the stapes, one of the tiny middle ear bones. Its job is to contract reflexively in response to loud sounds. This dampens the vibrations of the stapes, protecting the inner ear from noise damage. It's like a built-in earplug.
So CN8 is paralyzed, like in Bell's palsy.
Then the stapedius muscle is paralyzed too. That dampening reflex is lost. The stapes vibrates without restraint. This results in a condition called hyperacusis.
Meaning sounds seem louder.
Painfully louder. Every day sounds chewing, dishes clattering. Sometimes even their own voice can become uncomfortably or even agonizingly loud because that protective dampening mechanism is gone.
Wow. Okay, moving to CN8, the vestibulocochlear nerve. Hearing imbalance. What kind of pathology affects this?
A common issue here is a tumor called an acoustic neuroma, although it's more accurately called a vestibular schwannoma. It's a benign tumor that grows from the Schwann cells insulating the nerve.
And it usually starts on the vestibular part.
Often, yes. It typically arises on the vestibular division while the nerve is passing through the internal acoustic meatus, that bony canal leading from the inner ear to the brainstem, because it's slow growing.
The symptoms develop gradually.
Right. Usually the first symptoms are related to pressure on the adjacent cochlear hearing division. So the patient notices progressive one-sided hearing loss, often accompanied by tinnitus, ringing or buzzing in that ear.
And the balance problems come later.
Typically, yes. As the tumor gets larger, it starts to significantly compress the vestibular nerve fibers, leading to dizziness, vertigo, unsteadiness. Sometimes it can even press on nearby nerves like the facial nerve, CN7, or trigeminal nerve, CNV, if it grows large enough.
Okay, one last point in this area, orbital trauma. You mentioned the orbital rim is strong, so what breaks in a blowout fracture?
It's usually not the strong rim. A blowout fracture is typically caused by a sudden increase in pressure inside the orbit. Imagine getting hit directly in the eye with a fist or a ball. The pressure gets transmitted through the orbital contents.
Onto weaker parts of the socket.
Exactly. The floor of the orbit, which is also the roof of the maxillary sinus, is very thin, and the medial wall bordering the ethmoid sinuses is also quite fragile, almost paper thin in places, so the pressure blows out one of these thin walls.
And the orbital contents can spill into the sinus.
Yes. Orbital fat, and sometimes even one of the eye muscles, like the inferior rectus muscle, if the floor breaks, can herniate down into the maxillary sinus or medially into the ethmoid sinuses.
What would you see clinically?
Double vision, diplopia, especially when trying to look up if the inferior rectus muscle is trapped, maybe some numbness below the eye if the infraorbital nerve is damaged, and sometimes the eyeball itself might appear slightly sunken, which we call an ophthalmos, because some of the supporting fat has escaped the orbit. And finally, we arrive at the neck. This region is truly unique. It's the vital link, the narrow conduit between the head and the rest of the body, specifically the thorax.
Yeah, everything has to pass through it. Airway, foodway, major blood vessels, nerves. Plus, it houses important glands like the thyroid. Its internal organization must be critical.
Absolutely. And the key to that organization is the deep cervical fascia. It's not just one layer. It's a complex set of fascial sheets that compartmentalize the neck structures.
Yeah.
Understanding these compartments is vital, especially when dealing with infections.
How so? How does fascia control infection spread?
It acts like barriers or sometimes channels. Let's compare two potential spaces. First, the pretracheal space, which is enclosed by the pretracheal fascia surrounding the thyroid, trachea, and esophagus.
Okay, what happens if an abscess forms there?
That fascia attaches firmly down to the manubrium, the top part of the sternum. So an infection contained within that pretracheal space usually cannot spread downwards into the chest. It's walled off inferiorly.
But that's not true for all neck spaces.
Definitely not. Contrast that with the retropharyngeal space. This is a potential space behind the pharynx and esophagus, between the visceral structures and the prevertebral fascia covering the deep neck muscles and spine.
And that space does communicate downwards.
Dangerously so. The prevertebral fascia, and thus the retropharyngeal space, extends all the way down into the posterior mediastinum in the chest, potentially as far as the diaphragm.
So an infection there. A retropharyngeal abscess.
Has a direct, unimpeded highway into the chest cavity. This is a true surgical emergency. The abscess can bulge forward, causing difficulty swallowing, dysphagia, or speaking, dysarthria. But the major risk is rapid spread into the mediastinum, causing mediastinitis, which can be fatal.
Wow. Knowing which fascial plane is involved makes a huge difference. Okay, let's move to a well-known landmark, the carotid triangle.
Yes, a key anatomical region in the anterior neck, defined by the sternocleidomastoid muscle posteriorly, the superior belly of the omohyoid muscle inferiorly, and the posterior belly of the digastric muscle superiorly.
And its contents are mainly vascular.
Primarily, the structures within the carotid sheath run through here. You've got the common carotid artery, which typically bifurcates into the internal and external carotid arteries right within this triangle. You also have the internal jugular vein, IJV, the vagus nerve, CNX, and associated deep cervical lymph nodes. It's crowded.
Clinically, when palpating the carotid pulse in this area, there's a specific warning, isn't there?
Yes, absolutely crucial. You need to palpate lower down in the neck, away from the carotid bifurcation if possible. Right at that split point, there's a dilation called the carotid sinus.
And that's sensitive.
Very sensitive. It contains baroreceptors nerve endings that monitor blood pressure. If you press or massage too firmly over the carotid sinus,
You can trigger a reflex.
you can trigger a powerful vasovagal reflex. The body interprets the pressure as high blood pressure, and the reflex response is to drastically slow the heart rate and drop blood pressure. This can easily cause dizziness or even fainting, syncope, especially in older individuals. So gentle palpation and ideally lower down is key.
Good advice. Lastly, let's touch on the thyroid gland's blood supply. It's very vascular, needs a lot of blood.
It has an incredibly rich blood supply reflecting its high metabolic activity. It gets paired arteries from two sources.
Superior and inferior thyroid arteries.
Exactly. The superior thyroid arteries usually branch off the external carotids and supply the upper poles. The inferior thyroid arteries typically come from the thyrocervical trunk, a branch of the subclavian artery, and supply the lower poles. And these arteries interconnect extensively within the gland, a rich anastomosis.
So, multiple routes for blood to get in. What about getting out? The venous drainage.
That's also extensive, typically involving 3 pairs of veins. The superior thyroid veins usually accompany the superior arteries and drain upwards into the internal jugular vein. The middle thyroid veins also typically drain into the IJV.
And the inferior ones.
The inferior thyroid veins are a bit different. They drain the lower part of the gland and usually descend into the thorax to drain into the left and right brachiocephalic veins just before they form the superior vena cava. So quite complex drainage reflecting its importance. Hashtag #TaxTaxC outro.
Well, that certainly was a comprehensive journey today. We covered a lot of ground from the biomechanics of walking
Looking at that interplay of eccentric and concentric contractions.
to the protective layers of the skull, why scalp wounds bleed so much, the dangers of epidural bleeds versus subarachnoid,
And the critical differences in their presentation.
and then navigating the complex fascial highways and byways of the neck, understanding how infection can spread, and the vital structures packed in there.
It really underscores how understanding the detailed anatomy directly informs clinical thinking and practice. You need to know the structure to understand the potential problems.
Absolutely. We hit the lower limb mechanics, cranial protection, neurovascular pathways, and the neck as that critical conduit.
Which brings us to a final thought for you, our listeners, to mull over. We talked about the danger of retropharyngeal abscesses spreading down fascial planes into the chest.
Right, the prevertebral fascia offering that direct route.
So consider this. How might your assessment, or maybe just your level of concern, change for a patient presenting with what seems like a simple sore throat or pharyngitis if you knew they had a condition that potentially weakens fascial integrity? Maybe they're on long-term high-dose steroids, or they've had radiation therapy to the neck in the past.
So the barriers that normally contain infection might be compromised.
Exactly. Could that seemingly minor throat infection pose a much higher, more immediate risk of descending into the mediastinum in that specific patient? Something to think about how underlying conditions alter anatomical risks.
That's a really pertinent clinical question. Definitely food for thought. Next time, we're staying in the neck, but focusing more tightly. We'll be diving into the skeletal framework, delving deeper into those fascial regions, and really mapping out the muscles, as laid out in Chapter 9 of our source text.
Looking forward to exploring that complex region in more detail.
Thanks for listening to Bookfulness.